Thanks very much, Hugh. Actually, I'm going to give you another 4.5 hours of good stuff, I hope, over the day, so in the afternoon. So we're going to do... hope you're going to enjoy today, really. We're going to start it off with polydipsia and polyuria and a logical approach. And I want to give you some updates on where I think we are with diabetes mellitus. And Jodie's going to give us the cutting edge on hyperadrenocorticism, and we'll probably interact a little bit because we don't always agree on all of that. And then we're going to just follow up with hypercalcemia, which I'm going to use, hopefully, cases mainly to illustrate some of the important points. So, but first up, for the next hour and a half, no mistakes about time this morning, we're going to be talking about polydipsia and polyuria. And the first thing, just to make sure a disclosure, I have no sponsorships, etc., that should influence what I'm going to say in this presentation. And like everything, when we've been talking about logical approach to clinical problem solving, the problem definition is important. And with this problem, polydipsia and polyuria, that question that, just to make sure that we set the scene, are we really dealing with excessive water consumption or production of excessive volume of urine, or is it something else? And I apologise for those of you thinking, well, wow, that's just a really boring way to start. But remember, that is the essence of today. Is a problem well defined is a problem well on the way to being solved. Problem well defined, problem well on the way to being solved. Second thing, asking crucial questions about what we need to know to help us with that problem. My problem, make sure that you can all hear me. Is everybody able to hear me clearly? Yeah. Okay. If at any stage I start to go up and down in my intonation so that you can't hear me, don't sit there thinking, I wish you'd talk louder. Just say, talk louder. We're all friends here, okay? In fact, I like it when you interrupt. It makes me feel part of the team. So this slide just has those obvious points, but sometimes the obvious, we just sort of almost don't, it's so obvious to us we never think about it, and so you assume, and sometimes it's a mistake. I did a little study for this talk and another talk I'm doing in a little while now, looking at the animals that presented to the Royal Veterinary College. So now this is very artificial, but looked at the animals that presented to the Royal Veterinary College, Queen Mother Hospital for Animals, for essentially polydipsia and polyuria in their presenting complaint or for investigation of same. And this is factor, there were 15% of the animals that came in to see us with polydipsia and polyuria as the underlying problem being investigated by a primary general practice veterinarian didn't have polydipsia and polyuria. They had some form of variation on urinary incontinence or polyuria or dysuria. Now, I can say that with great impunity to an Australian audience because every single one of you in the room is saying, I would never make that mistake. And I absolutely agree with you. I know you would never make that mistake, but just in case, I thought I'd mention it. Okay? So the last bullet point is the confirmation. So how do we confirm that the animal has polydipsia and polyuria? Well, the first thing is we should have some sort of a guideline for what's average water consumption. And just as a reminder, 50 in a cat, 100 in a dog. Of course, that would be that will vary depending on circumstances. Dogs that are going to be spending a lot more time exercising in warmer climates may well have higher. And I'm not saying that's the average water consumption. That's what I'm saying. If you can evaluate at some level that they're drinking more than that, then you almost certainly have increased water consumption. Everybody comfortable? So then there's 5 different possibilities there. I'm not going to get you to vote on them because voting takes a bit of time and I really am going to be up against it for time this morning. But just want you to consider those 5 and then tell me whether you're comfortable or don't tell me, but let you evaluate whether you're uncomfortable with what I'm doing here. You can't base it on in-hospital monitoring. can't. And you certainly can't base it on urine concentration. Too many times now, a lot more times than 15%, I'll have referring veterinarians tell me, well, it's not polydipsic and polyuric, or I don't think it is, or they said it was, but I don't think it is because it's got a urine-specific gravity of 1035 or 1040. So what? Urine-specific gravity is very helpful, but it never, ever, ever, ever can help us confirm polydipsia and polyuria. You can have polydipsic and polyuric animals that have got concentrated urine when you examine them for absolute sure. Okay? You're saying, some people are saying, yeah, that's of course. Some people are saying, I'm not so sure. Let's explore that because we're going to talk about the logical approach. Clarifying the problem. Defining the system or systems that must be involved. This is getting either I'm getting older and more osteopenic, or these desks are getting more firmer as I get older. And then we have to decide whether it's a primary or a secondary involvement. And then, of course, we consider the types of pathology which are probable or possible. And I know many of you have heard that 3 days in a row now, but there's a couple of people in the room who are coming for the first time. So just want to run through. That's a very, very brief system approach. So, if the animal is truly polydipsic and polyuric, then I put it to you, I'd like to suggest to you, that there are only 2 possible explanations. Only 2. Every animal that's polydipsic and polyuric, and I don't care whether it's a Chinese hamster, a cat, a dog, a horse, a cow, or a ring-tailed possum, if it's polydipsic and polyuric, there are only 2 explanations. You guys are a bit slow out of the blocks this morning. Is it a trick question? There's a really interesting comment. Shouldn't number 6 be all of the above? What I'm asking you to tell me is every polydipsic and polyuric animal can be explained. I said there are only 2 explanations. And I've given you these explanations here. And do you think you can explain every polydipsic and polyuric animal on a combination of those 5? And the answer, I'm going to stop because I know what you're going to tell me. I'm sure I know what you're going to tell me. I hope I know what you're going to tell me. I'm just making a point. Excellent. Because, of course, they're diagnoses. And all of those diseases can cause polydipsia and polyuria, but they can't possibly be the answer to the question, what are the 2 explanations? Can they? They're too specific. We've got too specific too quickly. Which is fine. Which is fine. That's all I gave you the chance to do. But what I'm suggesting to you is there are only 2 possible explanations. 1, they're drinking too much because they want to. Or 2, they're drinking too much because they have to. And every single case of polydipsia and polyuria you can explain by those 2 different explanations. But they are, aren't they, very, very different explanations. Very different. 1, there's absolutely nothing wrong with my renal system. And 2, there is something wrong with my renal system. And it might be primary or it might be secondary. And that's how I'd like to discuss logically investigating polydipsia and polyuria with you this morning, rather than any sort of long-winded page full of, we go here, think about this. Don't do that. Don't start with all of those lists of differential diagnoses. Because the crucial question that you have to ask yourself in the polydipsic polyuric patient is, is this thing drinking too much because it wants to or because it has to? And you go down 2 completely different pathways. 2 completely different pathways. Let me ask you just to pause for a second and tell me how many people can put their hands up now in the room. Anybody in the room, put your hands up. All the people in the room, put your hands up who've never given prednisolone to a dog or a cat. Fabulous. So everybody in the room has given prednisolone to a dog and a cat. Put your hands up if you haven't given prednisolone to a dog and a cat any more than 100 times. Any less than 100 times, I should say. Any less than 100 times? So I've got everybody in the room has given pred at least 100 times to a dog or a cat. We've got around 100 people in the room, more than 100 times. That's 10,000 episodes of administering prednisolone to a dog or a cat collectively in the room. That's not counting me. Is that fair? That would count, therefore, as a relatively impressive intellectual power about prednisolone and what it does. And how often, when you've given prednisolone to a dog and a cat and you've rung up the owner a day or 2 later and they've said, so how it's going? They say, oh, it's going great, except it's not eating anymore and it's not drinking. Like never, right? They usually drink more water when you put them on pred. That's what you expect. So now I'm going to ask you the question, why? And I don't think it's an unfair question. You're a qualified scientist, a professional. You're administering a medication to an animal and you know it has an adverse effect, that they drink more water. So the client, the punter, is going to say, that's interesting, Doc, why do they drink more water? And you're going to say, I don't know, they do though. No, you're not. Well, not after today, you're not. What's the answer?
Make them urinate more?
Well, that would mean that the prednisolone modifies the kidney function. Is that yours? So if every animal is polydipsic,
I'm going to tell him.
That's what you're going to tell him. It makes it urinate more. But implied in that is, because we're all working here as professionals, implied in that is that the kidney is unable to concentrate the urine when the animal's on pred. So due to glucose metabolism, producing more glucose, it certainly increases glucose turnover. If you've got an animal that's on pred and you get it back in, how often is it going to be hypoglycemic or have glucosuria? No. So the answer to that question is no. Is it? No, absolutely. I hope I'm not making you feel uncomfortable because that's exactly what I want you to do. If you come to a conference like this and we don't challenge you, or you don't walk away with a new idea or think about something, then I reckon personally, if I'm involved, I've failed miserably. Because you guys have all got a lot of experience. So it's an interesting question, isn't it? So there's another fantastic comment. And if you read the textbooks, and in fact, if you still read the textbooks to this very day, written by specialists, it'll tell you, one of the things we'll tell you if you go looking, is that glucocorticoids interfere with antidiuretic hormone binding in the collecting tubule, and therefore they make them urinate more because they have partial diabetes insipidus. Interestingly, look up the textbooks with hyperadrenocorticism with people, or ask people who go on to pred, how often do they have polydipsia and polyuria? And the answer is, not at all. And yet the phenomenon of modification of antidiuretic hormone binding in the collecting tubule is just as potent in people as it is in dogs as it is in mice, or as originally reported. The impact of that modification is to increase urine volume by around 0.5%. So although it continues to be stated in the textbooks, it's clearly because you know, you've done the experiment many, many times. So not all that well controlled, I agree, but you've done the experiment. You're going to read that and say, a 0.5% increase in urine volume? That's bullshit then. That isn't the reason they're drinking more water. Let's hold that thought. Polydipsia and polyuria, drinking too much because it has to. So are we talking about our problem-based approach? We're talking about the system or systems that must be involved. Okay? It's drinking too much because it wants to. What is the system that must be involved? It's drinking too much because it has to. What is the system that must be involved? The answer, obviously, central nervous system, if it's drinking too much because it wants to, and renal dysfunction, if it's drinking too much because it has to. That tells me the kidney can't concentrate and almost certainly, in fact, certainly, equally can't dilute. If it can't concentrate properly, it can't dilute properly. So straight away, all those diseases that you think of when you think about a polydipsic and polyuric animal, if you're pattern recognising, I want you to start thinking about how I'm going to put them into these two categories and then a little bit more, and that's what we're going to cover over the next little while. Polydipsia and thus polyuria. Polyuria and thus polydipsia. It's drinking too much because it wants to, its increased urination is appropriate. It's drinking too much because it has to, it's unable to concentrate its urine volume and dilute its normal volume. Okay? Primary polydipsia. Well, what happened there? My pen's still working, is it? Excuse me one second. I'm going to keep talking, but I'm just going to need to adjust my pen. So, urine production should be determined by water intake, not by... Where are they? There we go. Not vice versa, right? And when water intake is determined by urine output, there has to be a problem with the ability to concentrate the urine, which means I have impaired renal function. Everybody is very comfortable with that little bit. So how can we easily measure how concentrated the urine is? Specific gravity. Using a refractometer. Everybody's got one? Everybody's comfortable? Let me just bear with me for 1 second. I can't do this. It's a bit of a shame if I can't draw. Hooray. Don't you hate it when it all works perfectly and you put a new battery in at the beginning of the week and it's, no, that doesn't work. Does everyone mind me drawing on the slides? My wife hates it. She says it's so filthy and messy. So, no surprise. Very important. Very important. In normal animals, urine-specific gravity can be anything from 0.001 to 0.050 or more, or greater than 1.050 in normal animals. So when people say this is a normal urine-specific gravity, it means nothing. Remember, when the fluid is filtered at the glomerulus, the specific gravity of the filtrate there is around 1.008 to 1.012. So, therefore, any time the urine specific gravity that you get in an animal is less than 1.008, the filtrate has been actively diluted. And I think one of the problems with this sometimes in people's understanding is that we use this idea of people saying, well, that's got dilute urine and therefore it might have a renal problem. Well, that's possible, but in fact what we're talking about when we say dilute urine is inadequately concentrated urine. Because if it's significantly dilute, it tells me straight away I have enough nephrons to dilute the urine. If I have enough nephrons to dilute the urine, I have enough nephrons to concentrate the urine. Urine-specific gravity of 1.008 to 1.012 has not been significantly modified. And I take time just to remind you about what happens with normal numbers of nephrons functioning. We have this creation of an osmotic gradient that increases in osmolality as it moves from the cortex to the medulla. And that osmotic gradient is created by the pumping of sodium and chloride out in the distal convoluted tubule. Okay? Remember that when it starts here, the next one. When it starts here, the osmolality is, let's say, around 300. And about 70% of the fluid is removed in the proximal convoluted tubule. So most of the volume is removed here in the proximal convoluted tubule, and it's all isotonic. But then when it goes down the loop and Henle and back out again, all this sodium gets pumped out. And then there's another 10-15% removed in the distal convoluted tubule. So by the time it arrives here, we've lost a significant volume of fluid. This is isotonic. This is isotonic. But here, I've lost lots of sodium. That's why I have this concentration gradient. So my question to you, I'm not going to ask you to do a me too. My question to you is, if the osmolality was 300 here, what do you think the osmolality is here? And I don't want you to give me necessarily a number. Do you think it will be the same? Higher or lower? Don't tell me. Just commit. Osmolality, the number of particles in a particular volume of fluid. The isotonic removal of fluid with equal numbers of particles, equal amounts of fluid and particles, is not going to change the osmolality. So although 75% is removed in the proximal convoluted tubule, the osmolality doesn't change. But after it's come through the ascending loop of Henle, where all that sodium and chloride's been pumped out, the osmolality will have gone down profoundly. The osmolality won't be 300, certainly won't be 400. It is, in fact, around 50. Or 35. And if you want a specific gravity, right? And if you think about it, that's the only logical explanation that can happen. If I take all that sodium and chloride out, I'm going to have drastically reduced the osmolality. So then it's up to the fluid passing down the collecting tubule, and if it's permeable to water, which it will be if there's normal amounts of antidiuretic hormone, as it moves down, it'll get more and more and more concentrated, And of course, therefore, but it's against a more and more concentrated interstitium, therefore fluid keeps moving out. Right? That's just a review of physiology. Nothing new there, just a reminder. Everybody comfortable? You're not comfortable. Which bit aren't you comfortable with?
You know when you say it's isotonic, I might be being big here. You know when you say it's isotonic, it's the number of particles in fluid.
I didn't say that. I said isotonic. Means the same osmolality in the tubular filtrate as it is in plasma. So that means the concentration hasn't changed of the electrolytes, etc., hasn't changed very much. Osmolality is numbers of particles dissolved that are active, dissolved or in a fluid, so the fluid can move but the particles can't. That's what produces osmotic gradients. So if I take all the sodium out of a fluid, then suddenly its osmolality must go down. If it's sitting in a situation where the sodium ions can't move. That's the isotonic part is in the distal convoluted tubule. The question was, but you're replacing them with the sodium-potassium pump. And if I look up there, I know it's a bit messy, but what I said was isotonic absorption in the proximal convoluted tubule, isotonic absorption in the distal convoluted tubule. So the work that happens in the convoluted tubules in no way changes the osmolality. The fact that you suck all that sodium out in the ascending loop of Henle makes it dilute. If you like, when it gets to the end of the proximal convoluted tubule, it's still 300. By the time it gets out of the ascending loop of Henle, it's 50. And then it's 50 here, and it's 50 here, and it's 50 here. And if they don't do anything to it, it'll stay 50. That's why, if I have no antidiuretic hormone, I have to have very dilute urine. That's why, if you have very dilute urine, i.e. urine that is hypostenuric, if you want to use that stupid word, or just let's think the number, less than 1.008, if the urine is that dilute, then the one thing that you can absolutely and unequivocally say is this animal has more than enough nephrons to concentrate its urine. Because it has more than enough to dilute it. If it can dilute it, it can concentrate it. Well, the process that's doing that normally is either it's drinking a lot of... So that's the... Well, it's drinking from the pool. It's got to be drinking from somewhere. If it's got urine that's that dilute... Well, and the other... Well, let's just explore it a little more. I mean, I'll have a stab at what might be going on with that dog, which would be really rude of me to do. But I just think, John, it's probably... This is where we get this question of what's going on in terms of drinking too much or urinating too much. But the point I'm trying to make, well, there's a couple of points I'm trying to make. One, if this urine in an animal on a urine-specific gravity is less than 1.008, whatever else this animal might have, it can't have significant destruction of numbers of nephrons that's causing it to be polydipsic and polyuric, because it can concentrate them. It might have something else that's stopping the nephrons working that's outside the kidney, but the kidney itself has to have enough nephrons to concentrate because it has enough nephrons to dilute. Point one. Point two, normal is anything. So I can have a dog that's drinking a lot and will have a persistently low urine-specific gravity, or I can have a dog that's drinking a lot because it wants to and it'll have urine-specific gravities all over the shop, from persistently one day 0.003 to 1.045 to 1.038, which is why you can't use the urine-specific gravity in any way to tell you about polydipsia and polyuria, or to help you confirm it. Because plenty of animals that are profoundly polydipsic and polyuric will have on occasions, urine concentrations of 1.035. That's been shown very, very clearly in the literature over and over again. So if our two disorders are primary polydipsia and then polyuria, in other words, renal dysfunction, let's think about primary polydipsia first, because that's perhaps the easiest. Primary polydipsia, drinking because of anything that affects behaviour and or the thirst centre. It's voluntary. If you want to call it psychogenic, by all means, but I think that's probably overstating it. It implies some level of, I'm not quite sure what, I just don't like the term, but if that's what works for you, that's fine, it doesn't really matter. The concept is what I want. Primary polydipsia is voluntary, it's behavioural. The urine-specific gravity will be readily modifiable. When we've looked at it in animals, we know it can range from 1.001 to 1.0550. It changes rapidly. As an example of one of these dogs just a month ago, 1.004, 1.045. 10 o'clock, 1 o'clock. There was a great paper that Utrecht published about 3 years ago that demonstrated that. So-called psychogenic polydipsia, any behavioural abnormality that can manifest in altered water consumption. Various medications, or at least one in particular. Which one would that be? Huh? That's why it causes polydipsia and polyuria. It's behavioural. Textbooks will tell you, unfortunately, that psychogenic polydipsia is an uncommon problem. I'm going to pause for literally a minute here and do a little soapbox. There was a paper that was published about 4 years ago, that suggested that the average life expectancy of dogs in the United States was 6.8 years. And another paper that was published about 3 years before that said the average life expectancy was about 8.4 years. And another paper that was published, all different authors, all from the same database, that suggested that approximately 50% of dogs with immune-mediated hemolytic anemia were dead within 6 months of diagnosis. Now, I'm seeing some frowns because you're thinking, really? They aren't really managing their immune-mediated hemolytic anemia patients too well. I do better than that. That's what you're thinking? Okay, lateral thinking, excellent. How many people, if I asked you, how many people would suggest to me that that would be about your expectation that 50% of the dogs with IMHA that you manage are dead within 6 months? Put your hand up. 2, 3. Everyone else, because they die earlier than 6 months? So I'm trying to use, what I'm trying to say here is, this is information done robustly and evaluated and published in peer-reviewed scientific journals. But it's based on data that's collected in referral centres. And you're all scientists, so I want you to tell me how appropriate is it for people to evaluate what's going on. Well, no, let me ask you another question. I don't know what the answer is to this in Australia, but I'll get an estimate from you. What do you think? What proportion of cases seen by general practitioners in Australia get sent to a specialist? Less than double figures. Sure. So in the United Kingdom, in our database, which is the Vet Compass UK database, I can tell you that the number is 5.3%. 5.3% of the total veterinary morass, if you like, gets ended up in specialists. And by no stretch of the imagination is that a random sample. So on what planet could you possibly justify talking to general practitioners about what should be happening in general practice on the basis of a non-randomly selected 5.2% of the population. We should be lined up and shot. Surely. Isn't that the stupidest thing you've heard in the whole week? Bloody embarrassing, that's what that is. And yet, that's where so much of our perception has come from. Oh, psychogenic polydipsia, this is very unusual. Bullshit. It's really common when you look at it in general practice, especially if you start chasing it. Dogs' behaviour changes, they often drink more. You know you do it every day almost in practice as you change their behaviour when you give them pred. It's a behavioural modifying agent. It's why dogs with hyperadrenocorticism drink more water, why dogs with pred drink more water. It's behavioural. Of course, they may have a urinary tract infection, they're more prone to that, but that's another story. That will be then a manifestation of renal dysfunction. Primary polydipsia is usually the cause of hyperadrenocorticism. Why do cats with hypothyroidism drink more water? Psychogenic. Put a cat with hypothyroidism that's drinking more water at home in a cage and see what happens. Invariably, they stop drinking. Patients with... Pardon? With hypothyroidism, with hyperadrenocorticism, or both? Yeah. Liver disease? In hyperadrenocorticism, it's all of it. In hypothyroidism, depending on the rate change, yeah. But most of you are seeing hypothyroid cats now. If you ask, I mean, I'm assuming it's like us, most of them are not coming in to see you because they're eating more. They're coming in because they're losing a little bit of weight, or you pick them up as a geriatric check. They haven't got to the stage where they're starting to have abnormal head noises. So how are we going to diagnose primary polydipsia? By exclusion. That's a lot of money. So I'm not disagreeing with you, but it's a lot of money. Really? What's primary polydipsia is likely to be a behavioural change. What other problems might you see? Why don't you just let yourself go for a second? Why don't you just? What would be the? No, don't give it no water. Don't give it no water. If it needs to drink, that will be a bad idea. Lock it up and no water. But no, just change its environment. Do something to change its environment. Put it in a cage and see what happens. That's why I said you can't use in hospital. My dog's drinking a lot of water. Okay, I want to establish how much water it's drinking. I'm a very thorough veterinarian. I'll put it in the hospital, get the nurse to check it and see how much water it drinks. How much water has it drunk today? Michael? Hasn't drunk any. Hasn't drunk any water in the last 6 hours. Mrs. Smith, you're wrong. Your dog doesn't have polydipsia and polyuria. Now, you're not going to do that. I know you're not going to do that. But that's the point. If it stops drinking when it's in hospital for 6 hours, you've got your answer, haven't you? It's drinking because it wants to. Now, you can do a whole lot of tests. But if it stops drinking for 6 hours when it's in hospital, if you can do that, if you can hospitalise your patient without getting your neighbours upset or your licence revoked, there it is. Go looking for the reason after that, but don't worry about its renal function, because it isn't a problem. Not necessarily. No, if you do a water deprivation test, it can take forever for them to change their urine-specific gravity. And you've got a dangerous thing happening then. Water deprivation tests, some people don't want to ever touch them, but I think they're a necessary and effective diagnostic aid. But you don't want to go there until you have to. So
How significant is the dullery washout?
That's a tough question for this hour of the morning, isn't it? I don't think it's particularly significant. I don't think it's something that you need to get too exercised about. People have talked about it for ages, but...
So what does PrEP do to the brain?
Oh, well, now we're getting into neuropsychology, and I'm absolutely not qualified to speak about it. It modifies all sorts of things. It modifies the satiety centre. No, I don't know. The short answer is I don't know. I know what some of the things that it does. It certainly changes and modifies lysosomal stability, and it changes to some extent neuronal pathways. But it gets a little query. It's a little hazy in terms of that. I don't think anyone's particularly comfortable. But it's not just PrED. It's any steroid, because you know steroids can be behavioural modifiers. Anybody who has had any interaction with a pregnant female would know that. I don't know why I said pregnant female. Anyone who would have interaction with any pregnant individual would know that there's changes. You've got anabolic steroids, well known for modifying behaviour in a range of different ways. Androgens modify behaviour clearly. So they're all the steroid, or not all of them, but a chunk of them all have a link between behavioural modification. It's one of the great tragedies of managing Addison's patients is that people are recommended to give far too much glucocorticoid, and one of the problems over a chronic period of time is you'll end up with behavioural changes in a proportion of animals. I'm never going to get this done in an hour and a half, but I'm more than, it's important.
I'm going to say is one of the effects is creating euphoria.
Absolutely. No, it goes in all sorts of different ways. So it's not always... I'm not sure that that's good or bad, but there's no way of predicting what it's going to do. But the point is, I hope you're getting comfortable now, is this can be absolutely a behavioural modifying change. So the other thing to say, of course, I guess to finish it off with the PrED. So if you have an animal that's on PrED for whatever reason, and the owner's pissed because it's urinating in the laundry or wherever it stays overnight because it can't get out, then it needs to urinate, or it's got incontinence because of overnight, because it needs to urinate because it's drinking so much water, what are you going to do? You're going to say, I'm sorry, but that's the way it's going. We're going to reduce the PrED. No, don't reduce the PrED. Keep the dose at whatever dose you need. Take the water away. Oh, but he really wants to drink. Bad luck. Not overnight. Before you take the water away, make sure you get a urine sample by cysto and make sure it doesn't have a urinary tract infection. Because the other reason why it might be drinking is because it's now got a urinary tract infection because it's been on PrED. 50% of 30... No, I won't. I'll do that later. All right? Primary polydipsia. Increased urination is appropriate. Renal dysfunction. It's unable to concentrate its urine volume normally. Increased drinking is required to maintain neutral water balance. It's abnormally increased, but it's essential. The water consumption is abnormally increased, but it's essential. It's an appropriate response to activated osmo and baroreceptors. Urine-specific gravity will be poorly modifiable and potentially inappropriate. And then one last thing to talk about urine-specific gravity. So greater than 1.012, obviously the urine has been concentrated to some degree, but that's not what we're interested in. What we're interested in is whether it's appropriate or able to concentrate it adequately. So 235, I said 300, 235. What's the number? 45 to 50. So that's why we get the fluid moving down out of the water. That's what the kidney's going to be able to do. If they need to concentrate the urine because the animal's dehydrated or because it's azotemic, then I need to see a urine-specific gravity that's greater than 1030. If it's 1025, it's not enough. It's inadequately concentrated urine. It's telling me there's a problem with my ability to concentrate urine. Normal is 0.001 to 0.050. In a dehydrated or azotemic animal, urine-specific gravity should always be greater than 1.030. So in a dehydrated or azotemic animal, anything less than 1.030 is inadequately concentrated. And that's what I want to know about. So I'd like to suggest to you to forget about all of that hypocynuria, well, forget about isocinuria and hypercinuria, and just think about, is it less than 1.008? I know I'm actively diluting. I can dilute. If it needs to be more because it's dehydrated, it needs to be concentrated because it's dehydrated or azotemic, they're my two gold standards, then it should be greater than 1.030, and it doesn't matter a jot if it's 1.017, 1.021, 1.028. It should, well, that's getting close, but 1.030 or more, really greater than 1.030. That's what we're interested in. That's what we're interested in as clinicians. And it should be a bit higher in cats. Sometimes people say in cats it should be greater than 1035 or even 1.040 because cats are basically adapted for drinking less water and having a more effective capacity to retain urine. So, if you like, just to spell it out, normal hydration, expectation of urine-specific gravity, anything above 1.001 could be considered reasonable or normal. Dehydrated, greater than 1.030 in the dog, probably 1.045, 1.040 in the cat. If it's azotemic, it's got to be greater than those numbers, the greater than symbol. If it's dehydrated, it's got to be greater than that. Got it? And then if you put in a whole lot of fluids and it's overhydrated and you start to think, wow, it's starting to get some pulmonary congestion and edema, you absolutely expect it to be less than 1.008. And remember, if it can make it that low, less than 1.008, then it definitely can make it this high. So we've done primary polydipsia, a quick discussion on urine-specific gravity. Now let's think about renal dysfunction. Two possible explanations. See, I like to do it in twos. Primary polydipsia, renal dysfunction. Renal dysfunction, two possible explanations. Structural renal disease causing loss of large numbers of nephrons. Inadequate numbers of nephrons to create that medullary hypertonicity. Or a set of extrarenal factors that stop the numbers of nephrons working properly. If I asked all of you, I'm not going to ask you to do this, but if I asked all of you to take the pad that you've got or your notes and write the word nephron as quickly as you could for the next 10 seconds, right? And let's make it easy for me and us and say, I've got 100 people in the room, and let's say you could write nephron 10 times, 10 pieces of paper with nephron on it. I'd have, therefore, 1,000 pieces of paper with nephron written on it. Correct? Okay. Now, if I said, all right, everybody except this side of the stairs, leave the room. And now I have, let's say I have 20 people. Write nephron for me as quick as you can. Maybe you might do a little bit quicker. Let's say you get 12 nephrons out of 10. So now I've got 20 people having written 12. So what have I got? 240 pieces of nephron. I don't have the 1,000. I can't. 20 people can't get me 1,000 no matter how hard you bust a gut. Correct? That is effectively structural renal disease. I've lost all my nephrons. I can't create the medullary hypertonicity. The other explanation, or the other exemplar here, another possibility, is you're all in the room. You're all back. Miraculous return of function. Okay? And now, I want you to write nephron for me on those bits of paper in 1 minute, but I want you to do it with your other hand. If you're right-handed, you want to write with your left. Left-handed, write it with your right. And I give you the 10 seconds. How many pieces of paper with nephron on are you likely to write? Let's say that I can read maybe 4 or 5, maybe 3. How many pieces of paper with nephron will I have it now? I'll have 300. Still nowhere near enough. But you're all here. But something's stopping you performing properly. Does that analogy work for you? So the top bullet point, everybody's gone. I've just got you guys busting a gut. Second bullet point, everybody's here, but something's stopping you working properly. And they're the two areas that we need to think about in terms of renal dysfunction. Structural renal disease, which is very unlikely, in fact, as we know, effectively not going to be reversible, and the situation where we can have a reversible scenario for whatever reason. And that's, of course, hugely important in terms of the context of us as clinicians. So if I think of, so structural renal disease, I hope needs no more explanation. We'll come back to it a couple of times in putting it in the context. But I'm thinking about extra-renal factors now. So if you like, in terms of our logical approach, clinical problem solving, what system must be involved renal? Is it primary involvement of the kidney? In other words, I don't have any nephrons. Or is it secondary dysfunction of another body system impacting on the kidney? We have extra-renal factors. The first, dysfunction of the collecting tubule. Either not enough antidiuretic hormone or abnormal sensitivity to antidiuretic hormone. The second, osmotic diuresis. Osmotically active particles in the filtrate reducing the osmotic gradient between the tubular filtrate and the medullary interstitium. The third, inadequate numbers of nephrons working because they can't create that medullary hypertonicity. This one, the medullary hypertonicity is there. This one, the medullary hypertonicity is there. Sorry. This one, the medullary hypertonicity is here. This one here, the medullary hypertonicity has been lost because although the nephrons are there in normal numbers, they're not working properly. So let's think about collecting tubule dysfunction, antidiuretic hormone vasopressin deficiency, lack of antidiuretic hormone or renal insensitivity. The urine-specific gravity is going to be what? Don't say low. Don't say low. How can you say low? Because what's low refer to? I mean, I agree with you, but let's... Pardon? Isostonuric. So you've gone back to these terms. And that's okay if that's what you want to do. But if I don't have enough antidiuretic hormone, what's the urine-specific gravity going to be? Hmm? One, 1.008 to 1.012, 2 less than 1.008, 3 greater than 1.012. Don't put your hands up. Should have put this in the me too, shouldn't I? The answer has to be 2. It's got to be less than 1.008. I don't have enough antidiuretic hormone. That has not in any way impacted on the amount of sodium that's been sucked out of the tubular filtrate that's created the medullary hypertonicity. Everything is as it should be until it gets to the collecting tubule, and now the collecting tubule is not permeable to water. So it doesn't matter a rat's ass what's happening outside the tubule, it will not leave, the fluid will not leave the collecting tubule, and therefore it will be dilute. Therefore I have to have 1.008 or less than 1.008 or less. And instantly you know that this animal has enough nephrons to concentrate and dilute its urine. Correct? Everybody happy now? If not, we can discuss it at the break. Hypostenuric, if you like the term, hold on to it. We won't split hairs, we'll call it 1.008 for this purpose of this. Okay? And it's going to remain that way regardless of hydration status, glomerular filtration rate or anything. That has to be. If I don't have enough antidiuretic hormone. Now, occasionally we'll get partial antidiuretic hormone deficiency, but that clouds the water a little bit, and generally speaking, it doesn't make a great deal of difference. What we're talking about is the principle: no vasopressin, urine-specific gravity, less than 1.008, maybe 1.007 in the cap. The whole point about all of this is what happens with antidiuretic hormone is it activates vasopressin receptors, and those vasopressin receptors modify aquaporin-2, which is a molecule in the cytoplasm, and it takes the aquaporin-2 molecule from the cytoplasm to the collecting tubule lumen, and water can pass down it and then out through the cell. So if you look at it like this, there's the tubular lumen in the middle. These are collecting tubules on either side, one side, the other side here. These are my vasopressin receptors, yellow things. These are my aquaporin receptors. This is water in the tubular filtrate, right? So vasopressin comes along and binds to the receptors, and that activates the aquaporin receptors to move from the cytoplasm to the luminal surface of the collecting tubule, and that allows the water to move down into the cytoplasm of the collecting tubular cell, and then from there out into the medullary interstitium, all happening down the concentration gradient. So the activation comes from the movement of the aquaporin receptor to the outside. And I show you that simply because you can see then that there are a number of steps in that pathway that can be interfered with by other things, including calcium and indeed glucocorticoids, but not significantly clinically. The glucocorticoid bit. So in our diagram where we've been looking at this, here's my osmolality of 1.008 to 1.012. I've sucked out all the sodium here. That's why it's gone from 235 to 45, or 1.001. And now this water will move out if I have normal amounts of antidiuretic hormone and normal tissue sensitivity. But if I don't, then there'll be less water moving out, even though this gradient is completely normal. Okay? Extrarenal factor causing renal dysfunction, type 2, osmotic diuresis. Everything is in place as it should be. Tubular filtrate has a higher osmotic pressure than normal. The tubular filtrate has a higher osmotic pressure than normal. Less water moves from the tubular lumen to the interstitium. The urine-specific gravity can be anything, although it tends to be above 1.015. Why can it be anything? Because the urine-specific gravity can be modified by the particles that are causing the higher osmotic pressure. In this analogy that we've got going here, now I've got a whole lot more blobs in there. So the water moving down that gradient is reduced because I have a reduced gradient, because it's not 45 in here now. It might be more like 180 or 100, something. Okay? Just a reminder about osmolality. It's about the particles that can't move being suspended in a liquid that can move. In high school, they used to talk about semi-permeable membranes. It used to drive me crazy. Semi-permeable membranes. So here's two, receptacles with clearly different concentrations of particles. So I'm going to change that receptacle in from 2 into 1, and I'm going to put in a, quote, semi-permeable, unquote, membrane. In other words, a membrane which allows the liquid that the particles are suspended in to move freely, but not the particles. So what's going to happen? Which way is the liquid going to move? From right to left. Is that right? I hope so. And of course, as it does that, things will change in terms of volume, because they'll equilibrate, so the concentration will be the same. That is, after all, simple effect of osmolality. That's why if I have a low albumin, and it is albumin, not protein, if I have a low albumin, very low albumin, I can have subcutaneous edema or fluid accumulating in body cavities, because the vascular compartment has a lower osmolality, so the water oozes out down its osmotic gradient. Why is it albumin, not protein? Because if you think about serum protein, let's say it's 50, let's say it's 60, then the normal construction is 30 milligrams per decilitre of albumin, 10, 10, and 10 for alpha, beta, and gamma globulin, right? And then milligrams per decilitre, or you might call them grams per litre, and now it's 311. Milligrams per decilitre, that's the weight. But the weight of an albumin particle is about 60 daltons, 60 K. And these guys have a molecular weight of about 400. So there are a bazillion more albumin particles than there are these guys. And it's all about, osmolality is all about particles, numbers. So albumin is the only thing that impacts on oncotic pressure. Everybody happy with that? The only time that's important in terms of polydipsia and polyuria is with, really, only time practically that we're going to deal with it in general practice is the situation with diabetes mellitus. But as you all know, but just to remind you, you know this, but just to remind you the understanding of it is, that's why in diabetes, the only time I'm going to have polydipsia and polyuria is when the hyperglycemia that might be present exceeds the renal threshold. I can walk around with a blood glucose of 10 and I won't be polydipsic and polyuric because I've got no glucosuria, and if I have no glucosuria, I'm not going to be polydipsic. That's why, as I'll tell you in the next lecture, although there are lots and lots and lots of people who are diabetic, they don't know they're diabetic. Polydipsia and polyuria due to extrarenal factor type 3, reduced numbers of nephrons functioning. Marked reduction in the numbers of nephrons available to modify the tubular filtrate. There are normal numbers of nephrons, however, they're not working properly. Normal numbers of nephrons working, reduced numbers of nephrons working. Same thing. My osmolality hasn't gone down as much, and I haven't created the same osmotic gradient. So I can't concentrate my urine as effectively. I can't dilute it as effectively either. I can't concentrate it, nor can I dilute it effectively. Reduced numbers of functioning nephrons can be due to the absence of nephrons, can be due to normal numbers of nephrons that are not working properly, and as a result, in either situation, there's reduced medullary hypertonicity. The tubular filtrate can't be properly diluted, nor can it be properly concentrated. Poorly modifiable urine-specific gravity. When's it inadequately concentrated? If the urine-specific gravity is less than 1.030 in a dehydrated or azotemic patient. Yep. Even if it's greater than 1.012, greater than 1.015, or some measure that you talk about as being isoscenuric. That's why I don't really like the term. Because it doesn't mean very much to us in practical clinical terms. Reduced numbers of nephrons, structural renal disease of sufficient magnitude to have destroyed large numbers of nephrons, that's structural renal disease, or reduced numbers of nephrons where there's an extra renal factor interfering with normal nephron function, functional renal disease. Many potential extra renal factors, various electrolyte abnormalities, hypercalcemia, hyponatremia, hypokalemia, any cause of significant endotoxemia. Everybody knows pymetron patients have polydipsia and polyuria. Why? Because they have endotoxins that interfere with the nephron's ability to create the medullary hypertonicity. You all know about urinary tract infections. When I ask you about a urinary tract infection, you say to me, I say clinical signs of urinary tract infection, you're likely to tell me stranguria, polyuria, hematuria, which are all signs of lower urinary tract disease. What signs do I see if I have upper urinary tract disease? Don't see it so commonly, except in certain diseases. What's the sign? What's a clinical sign referable to upper urinary tract infections? Bit of pain, maybe? Maybe. EUPD. Polydipsia and polyuria. Because I'll stop my nephrons being able to concentrate properly. Upper urinary tract infections will produce polydipsia and polyuria as the overwhelming clinical sign. No polyuria, no stranguria, and often not necessarily any microscopic abnormalities either. Liver disease, for a couple of different reasons. There's a combination of liver disease, primary polydipsia and potentially impaired renal function because of reduced levels of urea, which are also involved in the concentrating the medullary hypertonicity. Polycythemias, partly primary, partly affecting the, affecting the tubular filtrate, tubular's capacity to concentrate, create the medullary hypertonicity, and other examples. That doesn't matter, we're not here to give you information transfer about every single disease. That's what you look up. But you look it up in the context of thinking about normal numbers of nephrons with reduced function. So primary polydipsia, loss of large numbers of nephrons due to structural renal disease or impaired nephron concentrating ability. They're my 5 causes of polydipsia and polyuria in pretty much any animal you want to think of. Okay? I'd like to suggest that's how we start approaching them. 2 more concepts. 1, impaired urine concentration and azotemia occur because of different and potentially unrelated mechanisms. Whenever we talk about polydipsia and polyuria, people like to talk about azotemia. Let's just stop for a second. There's my 5 causes of polydipsia and polyuria, right? You all happy with that? But it's important to distinguish azotemia and impaired concentrating capacity. Azotemia is due to a reduction in glomerular filtration rate or possibly an inability of urine to exit the body normally. Yes. Is that right? You happy? Decreased GFR, or I can't get rid of the urine because I have some form of bladder obstruction. Now, to some extent, that might cause decreased GFR as well, I concede, but if I have a ruptured bladder, for instance, I'll be azotemic. I won't have necessarily decreased GFR, but I'll be definitely azotemic because I'm not getting rid of my urine. It's being resorbed, recycled through my peritoneal cavity. Okay, so you're happy with that? So I'll just go back to this for a second, and I want you to have a look at that, those 5 causes, and I hope you agree with me, that covers every single possible potential explanation for polydipsia and polyuria that you're going to encounter in practice. And then I want you to look at it again and tell me how many of those 5 explanations have to be associated with azotemia. And we get taught in vet school about this link, and absolutely understandably, because we're vet students, but we're not vet students anymore. How many of those 5 have to be associated with azotemia? Correct. Just 1. Just 1. The loss of large numbers of nephrons due to structural renal disease. That's always going to, if I don't have enough nephrons to dilute and concentrate my urine, most of the time I won't have enough nephrons to filter properly, so I'll be azotemic as well. There's a little window in dogs where that might change, where I have not enough to concentrate and dilute, but still enough to filter. Doesn't seem to be the case in cats. But definitely just 1, although we often tend to think of them together, and we can, and we should, because this is a very common cause of polydipsia and polyuria in certain situations. But it is worth remembering that azotemia is due to a, as I said, potentially unrelated, related or unrelated, but very different reason. Azotemia is due to decreased glomerular filtration rate or an inability to get rid of urine out of the body. 2 principal reasons, as I said, urethral blockage, which is going to invariably be characterised by typical clinical signs, polyuria, dysuria, hematuria, stranguria, a distended bladder which is readily palpable, or a ruptured bladder which is going to have a less obvious clinical picture, although it may follow on from this clinical picture. In fact, it usually does. So while I'm not discounting in any way the importance of azotemia because of post-renal problems, what I am saying in terms of the clinical context that we're thinking about these cases, these patients tend to advertise that they have a problem, especially if we take a thorough history and we define the problem. And they'll have urine in the abdominal cavity that's usually generally easy to aspirate. So azotemia due to a reduction in glomerular filtration rate is what I want to focus on. Azotemia is due to a reduction in glomerular filtration rate. Impaired urine concentrating capacity is due to primary or secondary renal disease interfering with renal concentrating mechanisms. Okay? So if the patient has azotemia, then what's the first question we should ask? Yeah, I think that's absolutely right. What's the urine-specific gravity? If the patient is azotemic and has a urine-specific gravity that's greater than 1.030, what can we say? It's got, if you like the phrase pre-renal azotemia, stick with it. What it's telling me is azotemia means I have decreased glomerular filtration rate. I can only have decreased glomerular filtration rate for one of two reasons. One, I don't have enough glomeruli. Two, I have enough glomeruli, but they're not adequately perfused. If the urine-specific gravity is greater than 1.030, I have to assume that a reason for the azotemia is there are enough glomeruli and they're underperfused. I don't really know whether there's enough glomeruli, but I certainly know there's a reasonable chance that I have enough nephrons to concentrate the urine properly, so I probably have enough nephrons to filter properly. Therefore, unless I've got a very unusual kidney disease where the nephrons are affected and the tubules aren't, and that doesn't happen very often at all. So therefore, I have enough nephrons to concentrate, I should have enough nephrons to filter, so the azotemia is due to not inadequate numbers of glomeruli, not this, underperfusion. What about if I have a dehydrated azotemic patient with a urine-specific gravity that's less than 1.030? It's dehydrated, it's azotemic, and its urine-specific gravity is less than 1.030. The urine is inappropriately dilute. There's a renal concentrating dysfunction. I left this slide deliberately like this because I wanted to cross out in front of you inappropriately dilute and write in inadequately concentrated. Effectively means the same thing, but I think in terms of the clarity of our thinking, inadequately concentrated. This animal cannot concentrate its urine adequately. It has a renal concentrating impairment. The azotemia could be due to whatever is resulting in the renal concentrating dysfunction, or it could be due to renal underperfusion. I don't know. Do I? For instance, you sort of say, give me a for instance. Okay, I'll give you a for instance. A simple one. Let's say the animal has a low potassium because it's had diarrhea and vomiting. Its diarrhea and vomiting is made it dehydrated. It's dehydration and it can't keep it, so it's dehydrated, so it's decreased glomerular filtration rate because of underperfusion. Right? It's only ever one of two. Not enough glomeruli, underperfused normal numbers. It's dehydrated. It's azotemic because it's got decreased GFR because it's underperfused. The low potassium will do what to normal nephron function? It'll stop the kidneys concentrating the urine. It'll stop the kidneys being able to create that medullary hypertonicity. So that patient will have inadequately concentrated urine and be azotemic. So as it says up there, the azotemia could be due, it could have structural kidney disease, or you don't know. You don't know. When it's greater than 1.030, you do know. When it's less than 1.030, you're not sure. You have to run through, that's when you have to run through and check out all the potential reasons why it might not be able to concentrate its urine. What about exactly the same, azotemic, urine-specific gravity less than 1.030, but it's normally hydrated? The urine is inappropriately dilute. Here we go again. Bless you. the azotemia is likely to be due to whatever is resulting in the renal concentrating dysfunction. In this situation, if it's got normal hydration and I can't concentrate, then I'm thinking about the azotemia is likely to be due to whatever is resulting in the renal concentrating dysfunction. That could be chronic structural kidney disease, or it could be the extrarenal factors. Structural renal disease, hyponatremia, hypercalcemia. We'll talk about hypercalcemia this afternoon. So we can't assume structural renal disease until we're sure calcium, sodium, potassium, etc. are normal and there is no evidence for liver disease, pyometra or other cause of impaired tubular function. That's all I'm trying to say. You know what I'm going to do? We've got 10 minutes. Just try, we'll do this case. We'll do this case very quickly as an illustration. Minnie, 5-year-old female Labrador, polydipsia and polyuria for 5 to 6 months, progressing to urinating inside the house with variable levels of incontinence. She's pruritic. She's got hematology that's unremarkable. She's got biochemistry that's unremarkable apart from a marginal alkaline phosphatase elevation. Physical examination. Systolic murmur over the fourth intercostal space on the left hemithorax, 3 of 6. Heart rate and pulse rate normal. Mild hyperkeratosis, erythema and alopecia around the tail base. She's got flea dirt. That's her. Pretty happy dog. What's our assessment? I'm going to do this really quickly because I don't want to hold up your morning tea, and this is, I've been doing your head in this morning, haven't I? Polydipsia and polyuria. Incontinence. Flea allergy dermatitis. Polydipsia and polyuria. There are only ever 2 explanations. What are they? Primary polydipsia or renal dysfunction. And I've got 3 different explanations for renal dysfunction. 4. Structural renal disease, not enough antidiuretic hormone, osmotic diuresis, normal numbers of nephrons that are not working properly because of an extra renal factor. Be one of those 5, always. The urinary incontinence means I've got some form of abnormality in my lower urinary tract, which might be manageable if I don't have too much urine volume, because I do have too much urine volume. And I have probably an unrelated dermatological problem. In-house tests, urine-specific gravity 1.005, Aza-Stix urea is within the normal range, everything's all right. The referring veterinarian has done this. What should we do now? Protein creatinine ratio. Everybody's going to have a different plan. Okay, that's a good point. We've got a 1+ proteinuria in a very dilute urine. Maybe that will be a problem. Was she spayed? Does it matter? Why? So you're doing the pattern recognition now. Just because she's an entire bitch, you suddenly automatically assume her uterus is playing up? Well, it's not. Just cut to the chase. I can't remember, actually.
Hospitalise her and see if she stop drinking.
Is the right answer, isn't it? Isn't it? Well, you don't know. See, there's your hematology and biochemistry. You have a look at it. I mean, you've got that because the veterinarian have done that. So we're already now $30 for the in-house tests, and in the UK, $150 for the haematology and biochemistry. You treat the fleas. Seriously though, come on. I've got polydipsia and polyuria. That's what's bothering the owner. They don't really worry about the fleas. She's a Labrador, you know, she's got a bit of flu. Okay, yeah. That could be. So you're on the point I'm trying to make with this dog is they can investigate her a lot, but I'm in the dark. I don't know whether she's got primary polydipsia or renal dysfunction. That's the question. That's the crucial question every single time with a polydipsic and polyuric patient. There'll be times where they're clearly unlikely to be polydipsic and polyuric because they're really unwell. Most dogs with behavioural change, they're going to be drinking more water, are going to be relatively well. But you're sort of, if you're thinking about the logic, the crucial question is it this or is it that? So why not do something to help you answer, is it this or is it that? And okay, we could treat the fleas, but the other thing is I want to change its environment. So change its environment, treat the fleas. Change its environment, put it in a cage and see how much water it drinks. Change its environment, get them to put it in the car and take it over to grandma's. If it hasn't gone there very often, see how much water it drinks over there for the morning or the afternoon. It could. It absolutely could. It could have had that. It could have lots and lots and lots of things. But what I want to do to start off with, and or what I'd like to suggest is worth thinking about to start off with, is deciding whether it could have urinary tract infection or some other explanation for renal dysfunction versus primary polydipsia. So I can start looking at all those things, and you might still want to do that. But that means you're going to end up going through the renal dysfunction first, and then if you can't find anything, then you'll go back to primary polydipsia. Okay, and would that? So the sediment was. You would have looked at the sediment, and the sediment was unremarkable. Does that mean it doesn't have a urinary tract infection? No. Not at all. You have to do a urinary culture to make sure you don't know whether it's got a urinary tract infection. Great question. That's why I like doing cases, because it gets people to think about where they are in the room and where they'd be in their own practice. What's the crucial question? The crucial question is which system or systems must be involved. Is it drinking too much because it wants to? Primary polydipsia. Is it drinking too much because it has to? What maybe our first diagnostic step I'd like to suggest to you is one of those. I didn't turn it into a me too. I'd suggest that one. You might want a urine culture. You might want to do that. I don't care. I would absolutely agree with you, Emma. It would suggest to me that what it doesn't have is any of the explanations for renal dysfunction other than it might not have normal vasopressin.
Or it's for something even if we put in a cage for a vasopressin, that's something for this, you can still have all that. It's still hyperate,
No, it's true, except how many hyperactive cases have got flea allergy dermatitis?
Well, maybe it was much worse and you had to be on steroids for the last 10 years, and this year it's been on steroids.
It's only 5. You really want this dog to have hyper A, don't you, Emma? No, absolutely. I'm waiting for someone. I'm here tempting you, being my used car salesman self, and I'm waiting for someone to say, I don't think it can have structural renal disease because it's got 1.005. Thank you. And might it have a urinary tract infection that's interfering with concentrating capacity? Well, it'll be really unusual if that's the case and it's got 1.005. Because if it can dilute it as well as that, then it can concentrate it as well as that.
Are you saying that every psychogenic polydipsic dog, when you put it in the cage, it will not be polydipsic?
Now, you know, I recognise a trap when I see one, Mark. Sometimes. I'm not saying that, of course not, because this is a biological system, and nothing is guaranteed. What I'm suggesting is that if the animal stops drinking when you put it in a cage, it's likely to have primary polydipsia. If it doesn't stop drinking when you put it in a cage, you're none the wiser. Because a group of animals will not stop drinking, that are drinking because of behavioural change, will not stop drinking when you put them in the cage. What I'm saying is that from the urine-specific gravity, we can say this animal has either primary polydipsia or some form of diabetes insipidus.
So if you put it in a cage and it stops drinking...
You guys don't like this concept, do you? No.
You just send it home and say, get over it then.
I've got 2 more minutes, Hugh. We just can't leave it on get over it. No, it's fair. But it's a great question. It's a great question. We didn't engineer this before, did we? You and I didn't have a conversation. No. So this is the point, right? It's okay for me to talk about psychogenic. We've got to look for reasons for it. But you know that you can have difficulty managing the behavioural changes. Emma's thinking maybe it has got hyperadrenocorticism. I'm thinking because it's got flea allergy dermatitis, that makes it less likely. We'll hear what Jodie talks about hyperadrenocorticism after lunch. She didn't drink any water. No evidence of incontinence when she's in the cage. We let her run for 16 hours. She drank 100 mils. Bang. Primary polydipsia. Question. Go home and get over it. Or something else. Primary polydipsia. So, of course, the question is why? What should we do now? Look for an underlying metabolic disorder that might cause primary polydipsia. The flea allergy dermatitis has got to make hyperadrenocorticism unlikely. Look at that haematology one more time. Just take a look at it. PCV's on the low side. Albumin's low normal. Oh, sorry, the cholesterol's out of sight on the wrong side. Cholesterol. Let me get rid of that hole. Cholesterol's on the low side. Albumin's on the low side. She has 2+ microcytosis. What's a metabolic explanation? Pardon? Think it was worth having a look for it? Ammonia was 350. Yes, she was 5. And she was intact. There's a shunt. So no, you don't necessarily send them home. You talk to them in terms of behavioural changes, but you go looking for them. This dog's had shunt. This is a dog we saw literally a month and a half ago. So the surgical management's gone okay so far, but they usually do. But I just thought it was a good case to show you, so I turned it into a case because I think it really emphasises quite significant. They'd spent a lot of money on this dog investigating its renal function and da-da-da-da-da. And as Emma says, it really, with a 1.005, it just took all this other stuff out of the mix. But they were trying to chase it having partial diabetes insipidus. So it had attempted 2 evaluations on vasopressin because they didn't want to do water deprivation tests. So, take-home message: primary polydipsia, renal dysfunction. Investigate them in any frequency or sequence that you like, that you're comfortable with, and that's not for me to determine, that's for you to determine. What for me to establish for you is they are the 2 explanations, and they will cover everything that you see pretty much effectively all the time. And if you think about it broadly and bring it back down, then I think you're going to be able to be comfortable in making sure they don't frustrate you or trap you, because these can be frustrating and trapping. Primary polydipsia, renal dysfunction. And the renal dysfunction banner, it's structural renal disease, or it's a set of disorders that stop the nephrons working properly, just like when I asked you to write with your wrong hand. And those 3 are not enough vasopressin, an osmotic gradient that reduces, an osmotically active particle in the tubule that reduces the osmotic gradient, or something that stops the nephrons creating that medullary hypertonicity, like high calcium, low sodium, low potassium, liver disease. They are the 5 explanations for polydipsia and polyuria. Morning tea.